Hello, my name is Rosita Zand Kargar, and I'm a pharmacy resident with Yakima Indian Health Service. I am here today to talk about medication use in diabetes management, focusing on some of the newer agents. Today's presentation will focus on recognizing the three main building blocks of diabetes management, being familiar with the different mechanisms of how the diabetes medications work, knowing the difference between the background and mealtime medicines, being familiar with treatment guidelines of diabetes management and clinical trials data of some of our newer agents, and last but not least, selecting medication regimens based on the patient's clinical characteristics and preferences. Diabetes is a blood vessel disease, and it is important to remember that healthy eating and physical activity are as important as taking medications. Remember that without the three legs of the table, your table will fall over. This is a handout that will be available to you to download. It really helps to lay out some of the different options we have. For example, if you go up to metformin, there you can see that it stops the leaky liver, and this is the first line medicine used even when blood sugars are good. And this holds true as we use metformin also in prediabetes. I encourage you to download and utilize this when selecting an agent and describing how an agent works to your patients. It is important to understand the difference between background and mealtime medications. Some of our medications, such as metformin, long-acting insulins, and pioglitazone, work in the background in controlling blood sugars, and therefore have a lower potential of causing hypoglycemia. On the other hand, some of our mealtime medications, which include the sulfonylureas, are SGLT2 inhibitors ending in Flozin, DTP4 inhibitors ending in gliptin, GLP-1 receptor agonists ending in glutide, and are short-acting insulins. These medications mainly target the mealtime sugars and therefore have a higher potential of causing hypoglycemia. Some medications are designed as combinations. They provide both the background and mealtime coverage. Insulin 7030 is a perfect example of this. It is important to remember as the diabetes advances, background medicines may not be enough, and that's when we have to start thinking about adding the mealtime coverage. This is the treatment guideline released and updated by ADA this past January. As shown in the upper bar of the chart, our first medicine is generally metformin. When it comes to selecting a second drug, it is really individualized, and it depends on what's going on with the patient and that's what leads to the confusion. There is no clear answer on whether you should do step 1, 2, or 3, and it really has to be individuals based on your patient's characteristics and comorbidities. For example, if you have a patient with a history of cardiovascular disease, selecting a GLP-1 receptor agonist with proven cardiovascular benefits is preferred. On the other hand, if you have a patient with a history of chronic kidney disease or heart failure, selecting an SGLT2 inhibitor is preferred in preventing heart failure hospitalizations and providing renal protection. But if your patient doesn't have any underlying cardiovascular or chronic kidney disease issues, and maybe they only have diabetes and hypertension, then you can really select any of other agents as your second line or third line. It is, however, important to keep in mind the other factors such as hypoglycemia, weight gain, or cost concerns when selecting an agent for your patient. I am going to start this presentation off by going through some of the newer classes of medications. And for the second half of this presentation, we will look at some patient cases to ensure the proper application of the information we learned when selecting an agent. Metformin is our foundation medicine and the first building block in our treatment algorithm. If your patient is not on metformin, you should investigate the reason. Some of the reasons of why your patient may not be on metformin are diarrhea, which is usually less with the extended release formulations. A second reason might be a chronic or heavy alcohol use. But know that there is no specific guidelines as how many drinks a day can increase your patient risk of diabetic ketoacidosis. In terms of active diabetic ketoacidosis, we shouldn't use metformin, but if your patient has recovered from it, then we can consider it. Metformin also is not recommended in patients with unstable heart failure, since with metformin adequate blood flow to kidneys is necessary. For kidney cutoff, anyone who has an eGFR of more than 45, we can start metformin and increase it to the max dose of 2 grams a day. But if your patient's eGFR is between 30 and 45, then you can only continue them, and the max dose on metformin would be 1 gram a day. And sadly, if their eGFR is less than 30, then you'll have to discontinue it. A recent randomized trial confirmed previous observations that metformin use is associated with vitamin B12 deficiency. This is compatible with a recent report from the Diabetes Prevention Program Outcome Study, suggesting periodic testing of vitamin B12. There are a lot of new medications now with additional cardiovascular and chronic kidney disease benefits, in addition to providing the glycemic control. When these newer agents came out about 10 years ago, they required them to go through vigorous studies to ensure that they were not hurting people. And what they found was that some of these agents within the GLP-1 receptor agonist class have very good data on providing cardiovascular benefits, and some of the SGLT2 inhibitors have also proven benefits in patients with heart failure or chronic kidney disease. Heart disease is one of the compelling indications of using a GLP-1 receptor agonist. The GLP-1 receptor agonist family are also one of the few diabetes medications that have proven weight loss benefits through slowing the gastric emptying, and chronic kidney disease benefits through slowing the amount of proteins lost in the urine. It is important to note that these agents are recommended as part of the glucose-lowering regimen independent of A1C. Among the three different agents within the GLP-1 receptor agonist group listed on this slide, dulaglutide or Trulicity has shown to have better weight loss profiles and is also less expensive compared to liraglutide and semaglutide. It is important to avoid duplicate therapies of DTP4 inhibitors and GLP-1 receptor agonists when starting a new regimen. Heart failure and chronic kidney disease are some of the compelling reasons of using an SGLT2 inhibitor. Combined findings from 4 large clinical trials of the 3 different SGLT2 inhibitors are highly consistent and clearly indicate robust benefits of SGLT2 inhibitors in prevention of heart failure hospitalizations. SGLT2 inhibitors have also proven weight loss benefits. This class of medication works through a unique mechanism of action by preventing the kidneys from reabsorbing the sugar. When considering renal function, an eGFR of 45 or higher is most effective in lowering the sugar levels. Keep in mind that higher the sugar level is, the more sugar lowering effect and more side effects your patients will see. Dehydration and urinary tract infections are the most common side effects seen in patients starting SGLT2 inhibitors, as this is mainly seen in patients with blood sugars more than 200. A recent trial of Credence has also shown proven chronic kidney disease benefits with SGLT2 inhibitors in patients with an eGFR of less than 30, which is independent of the glucose lowering effects. In patients at a higher risk of hypoglycemia, DTP4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and TZDs are agents of choice. DPP4 inhibitors work by preventing an enzyme DPP4 from breaking the incretin hormones. This class of medication affects the postprandial blood sugar and can only lower the A1C by about 0.5 to 0.8%. This class of medication carries a warning for causing joint pain and acute pancreatitis, and it is important to remember that saxagliptin and alogliptin are not recommended in patients with heart failure. The next class of medication, TZDs, which ends in glutathione, work by increasing the insulin sensitivity and often take at least 4 weeks to see the full benefit. Remember, this class of medication can cause fluid retention and is therefore not recommended in patients with heart failure, as it can cause or exacerbate heart failure symptoms. There is a big misconception about starting insulin, and it is often a hard conversation to have with your patients. It is important to let your patients know that you have been always on insulin your entire life and even before when you were born, because your pancreas makes it. It is important to break down the barriers and letting your patient know that starting insulin doesn't mean that you have failed other therapies, and it is also doesn't mean that you'll have to be on insulin for a lifetime. The ideal approach to insulin initiation is to start basal insulin, usually at 10 units daily, and focus on controlling the fasting blood sugars. It is important to work closely with your patient to titrate their insulin dose on a weekly basis to reach the fasting blood sugar goals. Some patients may require mealtime or short-acting insulin eventually. How much insulin did it take to reach the goal blood sugar can often give you a good picture of how functional your patient's pancreas is. Now we are going into the second part of this presentation and focus on applying the knowledge to patient cases. Patient case number 1. In this case, we have a 45-year-old female who was just diagnosed with diabetes today with an A1C of 7.9%. This patient's kidney function is good. I'm going to pause for a second and let you think that what will be the first agent that you would recommend for this patient. So hopefully your answer on this was metformin. Again, looking at the American Diabetes Association treatment algorithm, metformin is always our first-line agent. I would personally start this patient on an extended release formulation, as people often tend to have less GI side effects with it. I would also start at a lower dose and then titrate her to the max dose as tolerated. Patient case number 2. In this case, we have a 56-year-old male with good kidney function. He is prescribed metformin max dose and glipizide 5 mg BID. His recent A1C is 7.5%. The patient admits only taking 500 mg of metformin daily due to diarrhea. What intervention will you make for this patient? So hopefully you came up with the fact that we are going to do metformin and an extended release formulation, starting him with a lower dose and then titrating him to the max dose. Patient case number 3. This is a 40-year-old male seen at the emergency room. His weight was 80 kilograms, but he lost 5 kilograms just recently and unexpectedly. His recent A1C is 13.2%, and this is an increase from 5.2% from about 2 years ago. Blood and urine are currently negative for ketones in this patient. I am going to pause for a second. Think about what would you use in this case. So hopefully your answer was to start him on insulin. At the emergency room, he is going to be getting IV insulin and hydration. But when this patient is discharged, a good approach would be to start him on basal insulin and titrating to go fasting blood glucose, and add on the meal coverage insulin as appropriate. Also, looking at the patient's kidney function, this patient would not be a candidate to starting metformin. Patient case number 4. This is a 70-year-old female with an A1C of 8.4% and a BMI of 37. This patient has a history of heart failure and chronic kidney disease, and it is currently taking metformin and pioglitazone. I am going to pause for a second. Think about what would you use in this case. So hopefully your immediate response was to discontinue pioglitazone as it can exacerbate her heart failure. Also looking at both the patient's history of heart failure, chronic kidney disease stage 3, and the patient's BMI, selecting an SGLT2 inhibitor such as Jardiance would be an appropriate agent. I hope that you found this information presented helpful in designing the most effective pharmacotherapy plans for your patients. I've provided my contact information. If you have any questions following this presentation, please feel free to contact me. Thank you for your time and have a great day.